Hello everyone, welcome back to Dr. Sam's Anatomy classes. Here I'm going to solve this question paper of MBBS first professional exam, and this question paper is from JNMC Jawaharlal Nehru Medical College AMU Aligarh Muslim University Aligarh UP. Okay, so this question paper is for the students who admitted in 2019. The students admitted in 2019, and this question paper is of Human Anatomy, Paper 2. This exam was conducted on 7th of February 2021. It was a 100-mark question paper with 3-hour duration, and in this question paper, uh, there was this section A. Yes, section A, you can see the section A is of 20 marks. There were 20 MCQs. So I'll be solving these MCQs for you one by one. So the question number one is the muscle triceps surae is formed by popliteus plus soleus, soleus plus gastrocnemius, plantaris plus gastrocnemius, flexor digitorum longus plus flexor hallucis longus. So you should know that soleus plus the two heads of gastrocnemius that together form triceps surae. So this answer to one is B. That is the correct answer. Soleus plus gastrocnemius. Now let's have a fast revision regarding the back of leg because both of them are the superficial muscles of the back of leg. So before wasting time, let's be fast here. This you're seeing is the back of femur, and this you're seeing is back of tibia, right? Okay. And here you're seeing is fibula, right? Then here you're seeing is talus, right? And then here you're seeing is, calcaneum, this calcaneum. And to be more precise, calcaneum, if I'm drawing, I should draw it like this. Now start labeling it fast so that you remember the important bony landmarks. This, is depression on the undersurface of talus. This is called sulcus tali. This is sulcus tali. Then this depression on the on the upper surface of calcaneum is called sulcus calcanei, right? And in between the two, now this cavity formed here is called sinus tarsi. Okay, and here in between there will be two ligaments, out of which remember the lateral ligament. These are interosseous, intraarticular, interosseous, interarticular, you know, talocalcaneal ligaments. There are two ligaments, medial and a lateral. The lateral talocalcaneal ligament also is important. This has a specific name, and that is called cervical ligament. Okay. And what about this bony prominence here? What about this bony prominence here? This bony prominence here is called on the medial shelf-like projection from calcaneum. Remember, this is from the medial shelf-like projection from the calcaneum, and this is called sustentaculum tali. Sustentaculum tali. You don't focus on my spelling because this will be minute while you'll see in your mobiles. So just focus what I'm speaking. This is the sustentaculum tali. Now, another important thing is that talus posteriorly has two bony prominences. The lateral one is a bigger bony prominence. So this is important. This also is asked. So you should know what it is, that the lateral bony prominence on the posterior aspect of talus has something significant, and that is called os trigonum. Now, os trigonum is actually an example of atavistic epiphysis. Another example of atavistic epiphysis is coracoid process of scapula. Learn them, both of them. Because they were originally centuries back, they might be separate bones, but now they've been fused to some other bones. So that's why they're examples of atavistic epiphysis. Okay, then if it's asked, like, tell me which tendon, which tendon passes, sorry, there are two tubercles in the posterior aspect of calcaneum. And if it's asked, what is the tendon passes between the two tubercles on the posterior aspect of calcaneum, which tendon is this? Any guesses? And if they ask, like, what is the tendon that passes winds below to this sustentaculum teli? You need not worry, it's the same tendon. Remember that. So this tendon is like having two bony landmarks that it crosses, and this tendon is tendon of flexor hallucis longus. So it passes between the two posterior tubercles on the talus and then winds below this sustentaculum teli. The further course it will be like passing below the spring ligament, and it will cross by flexor digitorum longus and all. That will I teach you sometime else. Right now, then again, I'll talk about in back of leg. So in this tibia posteriorly has an oblique line that's called soleal line, and tibia, fibula at its upper end. This provides origin, like uh, yeah. So this you're seeing is origin of this muscle, one of the deep muscles of the superficial layer of the back of leg, and this provides origin to the peripheral heart. Any guesses what is a peripheral heart? And this muscle is a peripheral heart because it has venous sinusoids, and this actually helps in the anti-gravity venous return of the blood towards the heart. So this muscle you are seeing is in the shape of a soul. So this is called soleus, right? Then I'm having list of colors here, I think. So yeah, so I think should use a little different color. So this muscle, now the other muscle you're seeing is arising from the, you know, medial and lateral supracondylar ridges on, of femur, having two heads, and these two heads when they descend down like this, this will be like a bipinnate muscle with two heads, the lateral head and the medial head of gastrocnemius. Now this is superficially placed to soleus in the back of leg, and both the heads when they descend down they actually merge together along with the soleus such that they have a common insertion point. And that common insertion point, again, let me ask you that posteriorly on the calcaneum also there are two bony prominences. Posteriorly also on calcaneum there are two bony prominences. So this tendocalcaneus, like what you're talking is about triceps surae. Now surae, as already told you, is actually this is the lateral head of gastrocnemius, and here it is the medial head of gastrocnemius. So the three muscles, what I have mentioned is number one, number two, and number three. All of them together form triceps surae. Triceps surae. One, two, and three numbering, which I have mentioned, they together form triceps surae. Now, another important point that I should cover here, that that common combined tendon, or this tendon here you seeing is called tendoachilles. This is called tendoachilles or tendocalcaneum. If asked like where does it inserts on the calcaneum posteriorly, medially or laterally, the two tubercles. So help you remember this, you should remember that there is one more muscle running down here, and that muscle is, again I should use little different color. This muscle arising from above to the lateral head of gastrocnemius, from the lateral dilar ridge of femur. Now, because it's arising from femur, remember that this muscle is having less of fleshy belly and it is more of tendinous in its course, and it runs down deep below and it gets inserted. Remember that this muscle has an oblique course. This muscle has an oblique course. So this muscle is plantaris. This muscle is plantaris. So plantaris is having an oblique course in the back of leg, and it is one of the three muscles of the superficial layer of back of leg. But it is not counted as triceps surae, although you might get confused if you go on Google search. So better advised, follow what I'm telling, that triceps surae does not include plantaris. It is only soleus plus the two heads of gastrocnemius. Okay, then before winding up, let me tell you important points. Below, embedded in this lateral head of gastrocnemius, you might find sometimes a sesamoid bone called fibula in the lateral head of gastrocnemius. And you might find sometimes a bursa placed below to the medial head of gastrocnemius. This bursa placed below the medial head of gastrocnemius, this is called Brody's bursa. This is called Brody's bursa, which may infect and cause Brody's abscess, which may be cause of pain later on. So these are the important points relevant to the back of leg. It's done. Now let's move to next question. Question number 2. Ankle joint. Now talking about ankle joint, ankle joint is most stable in which position? They should have written it a better framed question. Let me complete it. Ankle joint is most stable in which position? This question paper, the sentences in the question are not very properly framed. Ankle joint is most stable in which position? This should be the proper question. So the choices are plantar flexion, dorsiflexion, inversion, eversion. Now, answer of course is dorsiflexion of foot. Now, this again is not very clearly mentioned. It should be slight dorsiflexion, because dorsiflexion can be to any extent, and that again might be a unstable position. So, the better question also is not completely written. It should be which position, and the answer should be slight dorsiflexion. And now let me tell you that if I'm not going to explain this question, because I have already uploaded a video, a demonstration video on gross specimen of foot. So better to understand this question and why this dorsiflexion is the most, slight dorsiflexion is the most stable position of ankle joint. Better go in my playlist on lower limbs and demonstration of specimen viva specimen videos. There you will find a video on this most stable position of foot. You can watch the video and understand it clearly. All the minor details about this question have been already explained in a separate video. Okay, so I think I should move to the next question now. Go in the playlist of viscera specimen in my channel, Dr. Sam's Anatomy Class. Okay. Now, question number three. Question number three is the gluteal muscle. Gluteal muscle. Let me use it. Now listen. Gluteal muscle used for intramuscular injection is gluteus medius maximus, gluteus medius, gluteus minimus, tensor fasciae lati. So all the muscles options they have mentioned here, they are all muscles of the gluteal region. You have to pick a single choice. A gluteal muscle used for intramuscular injection is. Now, because to explain it, so let me tell you this again. This question is not properly framed. This is, a not properly framed question because let me tell you, there are, ideally, the best answer. I mean, if this question would have been framed as that gluteal muscle uh, that should be used for intramuscular injection, then of course your answer will be gluteus medius. The gluteal muscle should be used for intramuscular injection is gluteus medius. But if you remove should be, now see what the question means. The gluteal muscle used for intramuscular injection. So, gluteus maximus, a lot many clinicians, lot many nurses, they randomly, they just put the injection in the supralateral cord into the gluteal region. Everybody knows it very easily. So there are, chance. I mean, most of the nurses, clinicians, they also put intramuscular injection in gluteus maximus, and that's not very much wrong. Even if you are, safe and secure putting the syringe and injection, then even gluteus maximus is a muscle to which you can where you can provide this intramuscular injections. So actually speaking, the answer to this, if you remove what I have edited, the gluteal muscle used for intramuscular injection is both gluteus maximus and medius. Now look here, I'll explain it. I'll try to explain it for you. If you are seeing here is ASIS, anterior superior iliac spine, and this is let's say the gluteal region, right? This is the gluteal region. Okay, this is iliac crest. This is the iliac crest, and you know that the muscles here. This is gluteus maximus. This is the paternal plane of muscle of gluteus maximus. It gets inserted into the iliotibial tract and also deep down to the gluteal tuberosity. But here, superiorly, this gluteus maximus, it actually, if you expose the, skin, then superficial fascia, then the deep fascia, that is called the gluteal fascia, what you'll find, the gluteus maximus covers all the muscles down below except gluteus medius. Now, this gluteus medius is actually here. This portion is by gluteus medius, right? And of course, here you find is tensor fascia lata. Tensor fasciae lata. This is gluteus medius. Now, partly medius is also below maximus as well, and this is gluteus maximus. What you're not seeing here is gluteus minimus, which is actually completely covered by gluteus medius. Below to this, not below to this, you will find is gluteus minimus. So below gluteus medius, you find is gluteus minimus. And the neurovascular plane supplying to these three muscles, you know, these three muscles, 1, 2, and 3. Medius, minimus, and tensor fasciae latae, they're supplied by superior gluteal nerve, right? while gluteus maximus is innervated by inferior gluteal nerve. So now let me tell you how to go for, intramuscular injections. Actually, first of all, you need to um, draw four quadrants. If you palpate down below here, you'll find is the greater trochanter. And here where somewhere, this is ASIS, here somewhere above you'll find is the iliac tubercle. So you just palpate the iliac tubercle and draw a straight line here passing below to the greater trochanter of femur. That makes it like a four quadrant. And it's easily said like you should give a syringe here in the superolateral quadrant of the gluteal region. But the ideal way here is that your index finger should actually be pointing the ASIS and your middle finger should be pointing the iliac tubercle, and your third ring finger you have a little finger and your thumb like this, right? So this should be the position of hand. And here you'll find is the knuckles, right? The knuckles here, the knuckles, then proximal IP and terminal IP joints. So somewhere in between the two digits, middle finger and the index finger, here you can plan out between the proximal IP joints of the middle and index finger. When you're placing your hand, this is your right hand on the left side of the gluteal region of the subject. There it is the best site. This is the best. This is the best intramuscular injection site, right? And this site actually, if you ask about the nurses, they are taught them as ventrolateral gluteal injection. This is said to be ventrolateral or ventrogluteal intramuscular injection. And as you've already seen that which muscle is actually it is going into gluteus medius, correct? But very commonly you must have seen that clinicians do not follow all this procedure. They simply pick up a syringe and they just prick the needle in the supralateral quadrant. So there are very much chances that the needle might pierce this muscle here, like without placing your hand and all, just reaching to this quadrant, you might place a needle here, here, all these sides, any of these sides in the supralateral quadrant, people just push the needle here. So there are chances that many times the needle goes into this muscle, gluteus maximus, and now this site is called as dorso dorsogluteal intramuscular injection. The dorsogluteal injection, dorsolateral or dorsogluteal intramuscular injection. Now this injection goes into gluteus maximus. So you know uh, uh, if they have asked that the gluteal muscle used for intramuscular injection is, so both these muscles can be used for intramuscular injections. Rather in this maximus, if you're talking about, you can go deep down below because there's much of enough of fat also. So entire needle of 1.5 inch might, you can prick it directly 90 degrees, you can go deep inside if you're pricking here in the dorsogluteal region. Ventrogluteal region also is like when is preferred because let me know the nerves here, here somewhere in this issue, behind you find is a spine, sacral spine, then you have, you know, ischial spine, and this is the greater sciatic notch, right? So somewhere down below, you'll find the sciatic nerve coming out, and there will be nerves, inferior gluteal nerve also reaching to this Gluteus Maximus and all. So if you are like, that's why it's avoided that your intramuscular injection should not go into the posterior half of the gluteal region or inferior half of the gluteal region. Then this muscle, from supragluteal, this greater sciatic notch. There is this key muscle of the gluteal region called piriformis, and the nerves and vessels emerging out of greater sciatic notch above piriformis is superior gluteal nerve and vessels. Now, superior gluteal nerve and vessels actually ascend up and they divide into two divisions. One is the superior and the other one is the inferior division. And this superior gluteal nerve, it runs in between gluteus medius and gluteus minimus. That's the neurovascular plane in the gluteal region. So here also you have to be precise that your syringe should not reach very much close to the iliac crest. Got it? So both of them are the muscles used for intramuscular injection, but ideally what should be the muscle is ideally, the safest and the best to practice is to give my intramuscular injection in the procedure that I have shown you here. And so I think those who have marked B should be given full marks, but Gluteus maximus, if students have marked, they should also be considered because the question framing was not very precise. Okay, so it's done. Now let's move to the next question. Question number 4. Question number 4 is about the base of heart is formed by. Base of heart is formed by right ventricle plus left ventricle, right atrium plus right ventricle, right atrium plus left atrium plus left ventricle. Okay, I'm explaining it here, but uh, there is a video already uploaded, but because it needs less of time, so let me explain it. Heart is a hollow muscular conical organ. And this cone has a longitudinal axis and an apex and a base. So the longitudinal axis of the heart is directed downward, forwards, and laterally. And this is a cone, right? So if this is a cone like this, right? And this is the longitudinal axis. This is the axis I'm talking, right? So like a cone, and cone has an apex. You must have learned geometry. So in a cone, the base is always opposite to the apex. Just learn this by now. That being a conical muscular organ, the base of the heart is opposite to its apex. If you learn this, you will never forget that what is the base of the heart. So seeing here now, this surface you are seeing is the posterior surface of the heart. Now this is the base of heart. This is the posterior surface of heart, which is the base of the heart. What you are seeing in front, this surface you are seeing, the surface you are seeing here anteriorly now. Now this is the anterior surface of heart. Of course, it must be resting on something that is the central tendon of the diaphragm, and down below the surface, down below this surface, people generally get confused with this as the base of the heart. Remember, this is not the base, rather it's the inferior surface of the heart. Now, inferior surface also called diaphragmatic surface of the heart. Got it? And it also has the lateral surface, or you can say is the lateral border of the heart. This is the lateral border of the heart. This is the lateral border, and this is the right border of the heart. This is the right border of heart. Okay. Now, I mean, superior, of course, you can you can add up. There is the superior border as well. This is superior. Actually, this superior border is not very well seen because it's like encroached by, the two great arteries, pulmonary trunk and arch of aorta, ascending aorta. Now, sometime they might find some relevant questions. I'll just fast revise it with you. Apex, is formed completely. Now, apex is formed by completely by the wall of left ventricle. Remember this. Apex is formed completely by the walls of left ventricle. Now, base, what they have asked in question, let's complete with the question first. In the base, they have asked what forms the base. So remember, base is formed, you know, most of the portion of the base, the bigger portion of the base of, is formed by right. No, 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 no. Yes. So the bigger contribution to the base is by left atrium, that is two-third. Left atrium contributes two-third to the base of the heart, and right atrium contributes one-third to the base of the heart. Now talking about the anterior surface. Anterior surface is basically, like this, and a little portion like this. It's formed mainly by right ventricle, plus on the right side, this much portion on the right side by plus right atrium plus left ventricle. This much portion is the left ventricle. So this is how the anterior surface is formed. Now about the left border of the heart. Left border, sorry. Left border of the heart. What forms the left border of the heart? Left border is formed by left auricle. Left auricle. That is like a spongy uh, portion of the left auricle made up of musculi pectinati. The left auricle plus left ventricle, that forms the lateral or left lateral border. This is the left lateral border. Then if they ask like diaphragmatic surface, what makes the diaphragmatic surface? So now diaphragmatic surface, the inferior surface of the heart is formed by, if they ask, so that remember that the inferior surface two-third contribution is from left ventricle plus one-third is by right ventricle. Okay. Superior border, if they ask, no, superior border, remember, is formed by, this right atrium plus right, basically right auricle. Now that is auricle. right auricle plus left auricle. And they're not seen because, in front they have these large vessels, you know, pulmonary trunk and ascending aorta. What else remains that can be asked here? Um, I think I have, like, told you the important points. And for details, right border of the heart. This is an important question. They might ask, like, what forms the right border of the heart? So remember, it is completely formed by right atrium. Completely formed by right atrium. However, it does ascends above and descends below also, along with SVC, and down below with IVC. So the right border is formed by superior vena cava above, then the right atrium, and then inferior vena cava down below. And here, is the openings, vena caval opening in the central tendon of the diaphragm. So this is all about the heart and important points. Then now let me tell you that important point is that if you hold on, if you open my YouTube channel, this question you can watch this in again. Go into my playlist, Viscera playlist. Go into my playlist, watch this album, the folder Viscera. There you will find this video on demonstration of heart that includes the apex of heart, surfaces of heart. All the details are given there. You can watch them and understand them in the gross specimen. Question number 5. The root value of sacral plexus is L4, L5, S1, S2, S3, or L3, L4, L5, S1, S2, or L5 and S1, S2, S3, S4, or L2, L3, L4 only and S1, S2. So the correct answer is L4, L5, S1, S2, S3. Correct. And let me tell you again that this question is not properly framed, because this, when they have written in the question as sacral plexus, it should have only sacral segments as the choices. Otherwise, they should better call it as lumbosacral plexus. So L4 to S3 is the lumbosacral plexus. Now, let me tell you, how these plexuses are actually formed. You know, that a spinal nerve. What is the spinal nerve? Let's say this is the spinal cord, right? This is the spinal cord. It has these nerve roots, and let's say this is, fast. I'm trying to cover up fast. Yes. So yeah. So these are the dorsal nerve roots. Actually, this all I have already explained in my lecture. They're already uploaded on typical spinal nerve. So there, this is the spinal nerve that is formed. This is what we are talking is called the spinal nerve, right? And this is the dorsal nerve root, and this is the sensory ganglion, or DRG, dorsal root ganglion. This is the effector or the motor or the ventral nerve root. This is ventral nerve root. Now, this spinal nerve, when it emerges out from the intervertebral foramen, it soon divides into two primary ramus. This is a ventral and a dorsal primary ramus. This also should be known. Now, This is the spinal nerve, which we also call as nerve trunk, right? And this is the dorsal primary ramus, and this is the ventral primary ramus. And in case this also is important, you should know that this is a sympathetic ganglion, right? This is a sympathetic ganglion. This is attached. Remember that sympathetic ganglion is attached to the ventral primary rami. Now about the plexuses, the nerve plexuses, in like cervical region, you have cervical plexus, then you have brachial plexus, then you have lumbar plexus, lumbosacral plexus. All of these are actually plexuses. They are all formed by this ventral primary ramus. They form the nerve plexuses, right? All the plexuses, cervical plexus, brachial plexus, lumbar plexus, lumbosacral plexus, all of them being formed by the ventral primary ramus. Then this ventral primary ramus, it also gives, it divides into its ventral and a dorsal division. So ventral and a dorsal division. Now this one is the ventral division of anterior primary ramus, and this one is a dorsal division of anterior primary ramus, anterior or ventral primary. So now plexuses actually, plexuses we're talking is about are formed by plexuses are formed by this. This is what is forming the nerve plexus. And these plexuses give out their ventral and dorsal divisions in the form of peripheral nerves. But again, let me tell you, the peripheral nerves, if you say like radial nerve, ulnar nerve, femoral nerve, common peroneal nerve, tibial nerve, all these nerves are actually, again, let me tell you, literally they are misnomers, because nerves they are actually being derived from like either primary ramus, dorsal primary ramus, or the ventral primary ramus. Nerve actually is this spinal nerve is what emerges out from the intervertebral foramen. Anyway, because we have to follow the parallels, the common parallels being used worldwide is that the peripheral nerves are actually all derived from these anterior and dorsal primary ramus. So let's complete this lumbosacral plexus fast, so that with this MCQ I should cover all the important MCQs that you might encounter in future. So let's, because this idea of ventral and dorsal ramus and the branches and how these plexuses are formed, they're also important. Now we'll talk about the lumbosacral plexus, right? So here I'm telling you is about the lumbosacral plexus. Now lumbosacral plexus, as I told you, this is being formed by the anterior primary rami. So here what I'm drawing is the anterior primary rami of anterior primary rami of L4, L5, S1, S2, S3. So these are, you can imagine what I've drawn is a cut section of these ventral primary rami of these spinal segments. So the nerves arising from these segments. Okay, then these nerves, as I told you, that these will divide these anti-primary rami, they divide into ventral division and dorsal division. So now what I'm drawing here is to make you learn easily that This is how, you know, the nerves from these three segments arise. From L4, L5, S1, the ventral division of the anterior primary rami, they together join to form this nerve called nerve to quadratus femoris. L4, L5, S1 ventral division. Similarly, from the same segments, the anterior primary rami will give its dorsal division to form this nerve that is called superior gluteal nerve. Okay, then from L5, S1, S2, L5, S1, S2, the antiprimary rami gives its ventral divisions to form this nerve called nerve to obturator internus. And the dorsal divisions from the same spinal segments will, give rise to this nerve called inferior gluteal nerve. Okay, then from S1, sorry, I have to complete it with S1, S2, S3. I should complete it with S4 also. Okay, S2, 3, 4 spinal segments, they also give this ventral and dorsal division according to some authors. But this is not so. So from S2, S3, and S4, there are ventral divisions which join to form this nerve, very important nerve, that is pudendal nerve. Also from the same segments, there is another nerve which is actually the parasympathetic outflow S234, right? And that is called pelvic splanchnic nerve or nervi regentis. Okay, so these are the nerves arising from the lumbosacral segments. There are still few more. I should tell them all. So yes, so there is nerve to piriformis. This nerve to piriformis is said to be the dorsal divisions from S1, S2, and occasionally it also gets a contribution from L5, and this is called nerve to piriformis. Nerve to piriformis. Then there is some other, nerve, and that is S2, S3. S2, S3 dorsal division. This gives a branch which is called perforating cutaneous nerve. Now, this perforating cutaneous nerve, of course, why it is perforating? Because what does it perforate? Remember, it perforates the sacrotuberous ligament, and it innervates the skin on the natis, that is the infromedial quadrant of the gluteal region. Okay, then another few important, the important nerves I have to tell you. So remember that from L4, the ventral divisions from L4, L5, S1, S2, S3, right? So all these ventral divisions from L4 to S3, they together form this nerve called tibial nerve. Okay, and then there is branches from L4, the dorsal branches from L4, L5, S2, S1, and S2. Not enough contribution from S3. From L4 to S2, these dorsal divisions, they form this nerve called common peroneal nerve. Okay, then together the two components, these tibial nerve and CPN, common peroneal nerve and they get enclosed in a common epineurium, and that is called sciatic nerve. Okay. Now, similarly, there is nerve arising from S1 dorsal division, S2 dorsal division, then also from S2 ventral division and S3 ventral division. They also get enclosed in a common epineurium, and this nerve is called posterior cutaneous nerve of thigh. So remember that posterior cutaneous nerve thigh, this also has a very important point to remember, that it is the cutaneous nerve which distributes or innervates the maximum area of the skin of human body. It has the largest territory or the largest dermatome on the human body, that is posterior cutaneous nerve of thigh. Okay. So one again, I should tell you that there are two problems with this question, not properly framed. One is that they have not written it as lumbosacral plexus because they've given lumbar segments in all of the choices. So the better ways was to write it as lumbosacral plexus. Another thing they have missed out is that they should include, you know, S4 also in this. Now moving to next question. Question number 6. All of the following muscles take origin from iliac crest except. Choices are gluteus maximus, latissimus dorsi, iliacus, erectus spinae. Answer, of course, is iliacus. Fast revision about the iliac crest. So let me tell you the upper superior border of the iliac crest. It's like this. Somewhat like, looking like a clavicle when you see from above. The curvatures and all are the same because like anterior anterior two-third is convex outside and the posterior one-third is concave outside. So now you got to know this is the iliac crest and this surface is the gluteal surface and this surface is the pelvic surface. And because I'm seeing the right iliac crest from above, so this becomes the anterior and this becomes the posterior end. Now talking about the attachments. So before that, let me tell you the bony prominences. This bony prominence is called anterior superior iliac spine, and this bony prominence is called posterior superior iliac spine. Then from this ASIS only the outer border, the outer lip of this iliac crest around 5 centimeter above, you find is a tubercle, and this tubercle is called iliac tubercle. Now about the ligamentous attachments. Ligamentous, or before that, let me cover the muscular attachments first. So from ASIS till iliac tubercle, on the outer surface, there is origin of this muscle called tensor fasciolati. Then there is insertion of a muscle on the outer border, anterior two-third outer border. There is insertion of this muscle, and of course this can be another MCQ sometime, that it is the only muscle that inserts on the iliac crest, and that is external oblique abdominis. External oblique abdominis. Then on the upper border of the iliac crest in the anterior two-third, there is origin of this muscle, and this muscle is internal oblique abdominis. Then on the inner lip, sorry, Then on the inner lip, there is origin of this muscle, the third or the deeper layer of the muscles of the anterior abdominal wall. This is transversus abdominis muscle. Then in the the anterior two-third posteriorly, you have this origin of muscle. This is the muscle of the back, and that is latissimus dorsi. And here you have on the inside is origin of this muscle of the posterior abdominal wall, and that is quadratus lumborum. And then posterior one-third on outer surface provides origin to this muscle called gluteus maximus. And posteriorly one-third on the inner surface that provides muscle to the deep muscle of the back, and that is erector spinae. Erector spinae is a very powerful, remember, erector spinae, masseter, gluteus maximus, these are very powerful muscles. And in case if they ask now what is taking origin from anterior superior iliac spine, there is this muscle called sartorius. What important point about this muscle is that it is the longest muscle of the human body, sartorius, a strap-shaped muscle. Then if they ask what takes origin from posterior superior iliac spine, so remember there are few fibers of gluteus maximus that take origin from posterior superior iliac spine. Okay, now what remains is about the ligamentous attachment. The ligamentous attachment, if they ask like what is attached to ASIS, of course you should know this is inguinal ligament. This is inguinal ligament. Inguinal ligament attached to ASIS, the lateral end of this ligament. Actually, you all know that's a holding of the abdominal fibers of external oblique itself. Then what is attached? The entire outer border. There is attachment of this deep fascia of the thigh, and that deep fascia which is attached on the outer lip is called fascia. Fascia lata. This is called fascia lata. Okay. And similarly, on the inner lip, there is an attachment or the fascia of the posterior abdominal wall, which continues below. Here it is called fascia iliaca. Fascia iliaca. Now this fascia lata on outer border of the iliac crest, it thickens and invests this muscle from ASIS till pubic tubercle. This gets thickened and invests this muscle. This thickening of fascia lata, which invests this tensor fasciae latae muscle, this is called iliotibial tract. Okay, this also has a lot of significance. I'll discuss about this sometime later. Because I've drawn this diagram, why not ask you some more thing? Like, the fibers of latissimus dorsi. The fibers of latissimus dorsi are ascending up like this, right? Going up towards the axilla and reaching forming the posterior wall of the axilla and reaching inserting into the humerus anteriorly, in the floor of the intertubercular sulcus. Then the direction of fibers of external oblique coming down and inserting here are like this. This is the direction of fibers of external oblique abdominis. Now the question arises, is the gap left out here in between the pattern of fibers of latissimus dorsi and external oblique, there's a triangle formed. The gap And you've seen that the apex, the base of this is formed by the iliac crest, the outer surface. This triangle is called lumbar triangle of Petit. Lumbar triangle of Petit is a common site for lumbar hernias. There's a weakness there in the flanks because of this. Sorry, not the flanks, rather it would be called the loins. Loins of the flanks and the posterolateral portion of the iliac crest. Now, question number 7. Cremastic reflex tests the integrity of spinal segments. T11 and T12, L1 and L2, L3 and L4, S1 and S2. Answer here is L1 and L2. Now let's revise what we're talking about is the cutaneous innovation here in males, right? We're talking it's about in males. So this is ASIS, and here somewhere you have is pubic tubercle, and this is the inguinal ligament. Now we will be talking about the cutaneous innovation here. Remember that the anterior one third of the scrotum and the adjacent portion of the skin on the perineum and the medial aspect of the thigh, this blue color area, this is innervated by ilioinguinal nerve, and the root number is L1. Then this area adjacent to that on the medial side of the thigh, here this much area on the medial side of the thigh, this area is innervated by genitofemoral nerve, femoral branch of genitofemoral nerve, and the root numbers are L1, L2. Then this is femoral branch of genitofemoral nerve, and remember that this area, it also is covering the area above the roof of the femoral triangle. So if it asks like what's the nerve supply of the skin of the roof of the femoral triangle, your answer will be again the same, that is femoral branch of genitofemoral nerve. There is another nerve here which supplies the skin above or overlying the inguinal ligament. This is by iliohypogastric nerve. The root number again is L1. And there is this inguinal canal here, right? So this is inguinal canal. So through this inguinal canal, there are two nerves that pass. They are passing through the inguinal canal. What are the two nerves that pass through inguinal canal? One, of course, is ilioinguinal nerve, and the other nerve that passes through the inguinal nerve is the genital branch of genitofemoral nerve. And this genital branch of genitofemoral nerve, as you've seen, that also has a femoral branch, this nerve, as well as a genital branch. So genital branch of genitofemoral nerve is motor in action, and this one is sensory. Femoral branch is a sensory division. So genital branch of genitofemoral nerve, it innervates which muscle? Cremaster. Okay. Now talking about cremastic reflex is, this cremaster is a loop-shaped muscle with fine muscle fibers. So when you stroke here, somewhere here is a scratch onto this medial surface of the upper medial surface of the thigh with like a key or like a back of your hammer that you use in your clinical postings. So when you scratch here, or stroke here on the medial side of the thigh, upper medial side of the thigh, the reflex, this is carried, the sensations now being carried by femoral branch of genitofemoral nerve. That is the afferent limb of this reflex, and the efferent limb will be now to contract this muscle, and that is through genital branch of genitofemoral nerve, and the root number of both of them is L1, L2, here also L1, L2. But remember one more thing, so you may not get confused later on, that the reflex is also being carried by this, the afferent limb I'm talking is also being carried by this nerve also, and that is ilioinguinal nerve L1. Because when you're scratching here on the stroking here on the peroneal side, as you're seeing in the above image, that area here is innervated by both ilioinguinal nerve in the upper portion near to the groins, and a little below on the medial side it will be by genital femoral branch of genitofemoral nerve. So the afferent limbs are by two nerves, ilioinguinal nerve and and femoral branch of genitofemoral nerve. Efferent is by genital branch of genitofemoral nerve. Root numbers will be L1, L2. Question number 8. The thymus is located in superior mediastinum, middle mediastinum, posterior mediastinum, anterior mediastinum. Answer. Now this question again is not a properly framed question, although the answer here will be superior mediastinum. But remember that thymus is also a content of anterior mediastinum, as well as it also is a content of neck. Now just fast revision about thymus so that you can remember relevant questions if they come regarding thymus. There is this, if you're seeing it from the front, there is this breastbone, and you have is this clavicle, right? The clavicle, both the sides, then the first ribs, right? The first ribs like this. Not going much into details, but and here somewhere you find is the trachea descending down like this. So what is the location of thymus? Actually, thymus is found here. Can you see the yellow colored thing which I have drawn? This is the location of thymus. That means it extends from the neck and it lies behind the sternum, the manubrium portion. This is the main portion of the thymus, that is, it's behind this manubrium, as well as it reaches into the neck and also into the anterior mediastinum. Or if you can see it in a lateral view, there you see it's this manubrium, then it is this body of sternum and xiphisternum. Remember, there is an angle called sternal angle, and you find is the first rib like this, and there is this spine from L1, sorry, T1 onwards, and you have is T12. So the lowest lying rib, which is the lowest lying rib, 9, 8th, 7th. So the lowest lying rib is 10th rib. Anyway, so we were talking about the space here, and down here you find is the diaphragm. The highest limit of the diaphragm reaches to which vertebral level? T8. So this mediastinum here, it's divided. Sorry, yeah, mediastinum is divided into the like this. Sorry, this is the mediastinum we're talking. Mediastinum is actually divided by the sternal angle into upper portion called superior mediastinum, And this portion down here is the inferior mediastinum. And inferior mediastinum is divided by this fibrous pericardium into three portions. You have anterior, you have middle, and you have the posterior mediastinum. These are parts of inferior mediastinum. Okay, now what is the location of thymus? Thymus is here. This is the location of thymus. Okay, and here you find is trachea, right? So location of actually it's this thymus, a brief important points. Remember the thymus at the time of birth it is around 10 to 15 or 20 grams, 10 to 15 grams at birth, then gradually it grows up, and reaches to size of around 30-40 grams at the age of puberty. And thereafter, in puberty, it starts, diminishing in size, decaying out, and most of it is being, replaced by the fat. And this thymus actually is made up of two irregular, not clearly demarcated lobes, and they're also, unequal in size. And the two lobes are actually joined, unlike by thyroid gland. Remember, there was thyroid gland was having an isthmus. You don't have an isthmus actually, the two lobe connecting. Rather, you have an areolar connective tissue which binds the two lobes of the thyroid gland. And this, is training for the. This is a lymphoid organ. It trains the T cells, lymphoid cells. So and the purpose of it is after puberty it is gradually diminishing in size. Right here now the thymus in detail is a part of immunology that will be taught in detail in your immunology portion. Right now to tell you about the location of thymus. So thymus, remember, if it's asked, the the bulk of it is situated behind the superior mediastinum. This is the exact location of superior the thymus here. It also reaches to the anterior mediastinum and to the neck also. So this should be the question. If it had been better framed, it had been framed, the thymus is mainly located in. So the answer will be superior mediastinum. Question number 9. Posterior surface of the head of pancreas is related to all except inferior vena cava, aorta, terminal point of renal veins, and bile duct. Answer here will be aorta. So, a fast revision about this gland. It's both endo and exocrine gland, and this is how it is. Slightly, the longitudinal axis, it's slightly transverse, located at the level of L1, L2 spinal vertebral levels, and it's slightly tilted upwards on the left side, and all the important things. Then the parts of this pancreas. So remember that this portion here, I should use some light color. So this much portion here is the head of the pancreas, and it includes this uncinate process of the pancreas. Then this much portion here is the neck of the pancreas. This is the body, and then the tail of the pancreas. So you've got to know the different portions. This is the head. Head portion is this much. Neck is this much. This is the body of pancreas. This is the tail of pancreas. Not talking about the relations, because they've asked is the posterior surface. So the posterior relations. So let me tell you, it lies behind to this inferior vena cava. The head is completely related behind to this inferior vena cava, and because posterior things we draw in a dotted line. So it's like related to the terminal portions of the two renal arteries, renal veins, the two renal veins will be terminating here in the inferior vena cava behind the head of the pancreas, and it is somewhere here you find is the abdominal aorta. So abdominal aorta is like this, and it's like running behind to the uncinate process of pancreas. So this is the uh, uncinate process of pancreas reaches anterior to the abdominal aorta. Now, what other structures important here is that this abdominal aorta emerges out through the abdominal thoracic abdominal diaphragm, right? And the diaphragm has these crust of the diaphragm. So these crust of the diaphragm, both right and left crust. So this crust, the right crust is longer in length, reaches from T12 level plate, then it reaches descends down L1, L2, L3. So this is longer, but left crest of the diaphragm is not so long. It reaches till L1, L2 segment spinal vertebral levels. So the another thing now to keep noticing the posterior relations of the head of the pancreas. When you have seen IVC, then you have terminal opening portions of the renal vessels, renal veins draining into the IVC, and the right crest of the diaphragm passing behind to this head. And don't forget, mm, I should use this because there is this duodenum place like this is the duodenum, C-shaped towards the right of the head of the pancreas, and there is this no common bile duct, terminal portion of the hepatic duct as well as the bile duct, and this terminal portion of the hepatic duct, the common bile duct, including this pancreatic duct also, it is in posterior relation to the head of the pancreas, and it is partly embedded in the substance of the pancreas. So these are the points you should remember in posterior relation. One is IVC, second is the renal vessels, both the sides renal vessels, right and left, renal veins, then this bile duct CBD, and then you have is, yes, the crus of the diaphragm. This is the crus of the diaphragm that is posterior related to the head of the pancreas. Okay. Sum up this. In case if the next asks like in anterior relation, so remember in anterior relation to the uncinate process, there will be this superior mesenteric vein and the superior sorry Mhm. Yes, superior mesenteric vein and superior mesenteric artery, they lie in anterior relation to the uncinate process. And behind the neck, this superior mesenteric splenic vein, they join to form the portal vein. All this is happening behind the neck of the pancreas. Neck is this much, you can remember. So posterior relations of the neck, you can remember that it is the superior mesenteric vein, terminal portion of this splenic vein, the joining to form the portal vein. Question number 10 regarding celiac trunk and its branches, which is a wrong statement. Left gastric artery is the smallest branch. Splenic artery runs behind the surface of pancreas. Right gastric artery is a branch of proper hepatic artery. Short gastric arteries are branches of splenic artery. This question is already, I have it's a repeated question. I have already solve this question in detail. If you go in my playlist of MCQs in my channel, you will find there's this question already been explained. But for those who are new to this question, let me be fast in explaining it. So remember what I'm drawing here is, oh shits, oh shits. Yes. Okay. Yeah. So what I'm drawing here is the stomach, right? This is the stomach. Then you can imagine that what I've drawn here is something behind the stomach. May not be like, I think I'm not very much uh, symmetrical, but the purpose here is to show you the arteries. So you have to focus upon the arterial pattern. And you know that this pancreas, if, as I told you, there was this neck portion here, and here it has a, you know, prominence, a tubercle on the superior border of the pancreas, and this tubercle is called tuber omental. So, and this vertebral level, let's say this vertebral level is, you know, T12 here, T12, L1, L2, right? So at the level of T12, L1 junction, here you find is the celiac trunk. I mean, just above to the tuberomental, you can say, or at the lower border of T12 also, you can say there is the celiac trunk. I think to be more precise, you can remember that T12 is here. Sorry, T12 is here, right? So at the lower border of T12, you find is the origin of celiac trunk from the abdominal aorta, and it is the artery of all the structures derived from the foregut. So now the branches here, uh, this branch here, the smallest branch is this artery, which ascends up and then it enters into this lesser omentum attached here. So you remember that there was this lesser omentum, right? This is lesser omentum. So this artery, this is left gastric artery. And then through the free end of this lesser omentum, it enters back and follows this lesser curvature of the stomach. Then the other branch is this branch which runs towards the right, and this is the common hepatic artery. So the common hepatic artery, it soon gives its descending branch, and that is called the gastroduodenal artery. This gastroduodenal artery descends down like this, and it soon divides again to give this branch here along the greater curvature of the stomach, and this is called the right gastroepiploic artery. This is the right gastroepiploic artery, and this continues down along this, the second part of the duodenum, and this is called the superior gastroduodenal no, this is called superior pancreaticoduodenal. This is superior pancreaticoduodenal. Pancreaticoduodenal artery. This is gastroduodenal artery. So this common hepatic artery is another branch from the celiac trunk which divides into gastroduodenal artery, and this artery is proper hepatic artery or hepatic artery proper. So from this hepatic artery proper, there is this branch given out, and this branch, you know, This branch here is given out and it again ascends up along the lesser curvature of the stomach, and again remember the thing that it will also run within this attached border of the lesser omentum, within along the lesser curvature of the stomach. So this artery is the right gastric artery. So right gastric artery is a branch of proper hepatic artery most often, but sometimes, no doubt, sometimes it might, the right gastric artery may also arise from common hepatic artery, but sometimes, but more commonly, it is a branch of proper hepatic artery. Now this proper hepatic artery will ascend up and will give a branch to the gallbladder, that is cystic artery, and will divide into right and left hepatic arteries to the two lobes of the liver. Then there is another important artery, and this artery is running over to the superior border of pancreas and reaching towards the tail to supply the spleen attached there. So this, you have noticed one important thing about this artery. Now this is a splenic artery. A splenic artery on its course will of course be supplying blood to the pancreas like this pancreatic branches, but out of that one branch will be a bigger branch, and this branch is called arteria pancreatica magna, right? Or otherwise these are pancreatic branches of the splenic artery. This artery is splenic artery. So here it also gives along the greater curvature these small branches, and these are called short gastric arteries. And it will also give a branch along the greater curvature of the stomach, and this artery is called the left gastroepiploic artery. So both these left and right gastroepiploic artery, now they also are running in the attached margin of the greater omentum, towards the along the greater curvature of the stomach. So what have you noticed the important points here? One thing is the branches of, one is left gastric artery, the smallest branch, remember, the smallest branch. But one thing about left gastric artery is that although it may be a small artery, but its distribution and contribution to the stomach is very large. It gives a lot, enough amount of blood supply to the stomach is by left gastric artery, and even the lower end of the esophagus also. So it reaches above to the diaphragm, to the esophageal or the muscular opening. So that was left gastric artery. Then you have is proper hepatic artery. Oh, sorry, no. Yeah. So yes, the other branch is common hepatic artery and splenic artery. Three branches. An important thing about splenic artery is that it runs along, remember, along the superior border of pancreas. It runs along the superior border of the pancreas. Another important thing that it is a tortuous. It's a tortuous artery. So this was important points. Now you've got to know the answer regarding celiac trunk and its branches, which is a wrong statement. Answer will be this. They've wrong asked is the wrong statement. So splenic artery runs uh, along the upper border of the pancreas, not behind the surface of the pancreas. Okay, it is the spleen, a splenic vein. If they ask, like, a splenic vein, you can write it. A splenic vein actually runs behind the pancreas, behind the surface of pancreas. Okay, question number 11. All are tributaries of azygous vein except hemiazygous vein, accessory hemiazygous vein, right first posterior intercostal vein, right bronchial vein. So just a fast revision about this also. Remember that this is the azygous vein, right? This is azygous vein, and you know where it drains? Actually, it arches over the root or the right lung or the hilum of the right lung, and it drains into this superior vena cava. Superior vena cava, you know, it divides into right and left brachiocephalics, but the left brachiocephalic vein is much longer and it lies behind the superior mediastinum, behind the manubrium, upper portion of the manubrium. And it is somewhere here you find is the manubrium sterni. Manubrium sterni is like this. And in case if there is location of arch of aorta, this is the location of arch of aorta. So what lies behind to the upper portion of manubrium is left brachiocephalic vein, and what lies below to in the posterior lower portion of manubrium, it is the arch of aorta. So we're talking about azygos. Azygos, you know, is formed by the lumbar ascending veins, and the lumbar azygos. Lumbar ascending veins, lumbar azygos, that will be taught in in abdominal portion. Right now we are talking is about the venous drainage of the thoracic wall. So on the right side, there is this posterior first posterior intercostal vein. This is the right first posterior intercostal vein that drains directly into the right brachiocephalic vein. Then the second, third, and the fourth. I think I should draw it in a better way. This should be like this. You know, yeah. So this is the second, third, and fourth posterior intercostal veins. They drain into the azygous vein via this common vein, and this common vein is called right posterior superior intercostal vein. Then you have this fifth, sixth, seventh, eighth, ninth, 10th, 11th, and the 12th, we don't call it as intercostal because it's below the 12th rib, so it is called subcostal vein. And these are 5, 6, 7, 8, 9, 10, 11 posterior intercostal vein of the right side. That is the drainage of the azygous vein. And on the left side, remember the first posterior intercostal vein from both right and left. This is the left first posterior intercostal vein that drains separately into the left brachiocephalic vein. Then you have is the second, third, and fourth. Second, third, and fourth left posterior intercostal veins. They drain through this common vein, and this is called the left posterior superior intercostal vein that drains into the left brachiocephalic vein. Now, the fifth, sixth, seventh, eighth. Now, venous drainage from, let's say, fifth, sixth, seventh, and eighth intercostal spaces. They join together and then they cross the spine anteriorly to this vertebral level. Which vertebral level will be this? Yes, it is T8 vertebral level. And this vein is accessory hemiazygous vein, draining 5th, 6th, 7th, and 8th left posterior intercostal veins. Then the lymphatic drainage from, the subcostal vein. This is subcostal vein on the left side. This is on the right side. And then you have is 11th, 10th, and 9th. Right, so this is 9th, 10th, 11th, and the subcostal veins on the right side, they join together and they form this common vein which also crosses the spine anteriorly and it also drains into the azygous vein. Okay, so this vein is called hemiazygous vein. To remember this, remember for your convenience, A for accessory, A for above, H for heavy. Heavy means something down. So this way you can remember accessory lies above and hemiazygous lies below. So it's 12 we can remember. On the right side, it is only the first that drains separately, but the rest of the posterior costal vein directly drains into the azygous on the right side. And on the left side, you have divided into 4, 4, 4. So upper four intercostal vein drain directly to the left brachiocephalic vein. The middle four intercostal veins on the left side they drain to the azygous vein. No, accessory hemiazygous vein, and the lower four posterior intercostal veins on the left side, they drain to the hemiazygous vein. Cross anterior to the T8 spinal vertebral level. Now about the bronchial veins. So remember that the bronchial veins, I should mention about the bronchial veins also. So look here, now bronchial veins on the, I'm mentioning it like this, so you remember this is the right bronchial vein. So the right bronchial vein drains directly into the azygous vein. Now regarding the left bronchial vein. Now the left bronchial vein has two options. Left bronchial vein may drain either into the left superior intercostal vein, or it might drain into azygous vein. This is a left bronchial vein has two options, either into left posterior intercostal vein or into the accessory hemiazygous vein. Just because we have crossed these, talking about these bronchial veins, remember bronchial arteries also. Bronchial arteries on the right side and the left side. On the right side, you have only one, and is a that is a branch of right third posterior intercostal artery, right? And on the left side, you have you know, two branches, and they are direct branches of thoracic aorta, descending thoracic aorta. Okay. Question number 12. A muscle which flexes both hip and knee joint is Gluteus maximus, bicep femoris, rectus femoris, sartorius. Answer here will be sartorius. Okay. So sartorius, sartorius crosses the, sartorius is like this, right? Sartorius is like this. So it actually crosses two joints. It crosses, this is the head of femur, and this is like condyles of femur, and uh, the condyles of femur are here like this, and this is tibia, right? So this is how it is. So actually it crosses two joints, like a hip joint and the knee joint. So the action of sartorius will be flexion of hip, because flexion of hip is anterior, anterior bending of the thighs, and flexion of knee is posterior bending of the leg. Got it? So sartorius flexes both hip and knee joints. Gluteus maximus is a powerful extensor. This is a powerful extensor of the thigh, and bicep femoris is of course a hamstring, so it flexes the knee as well as extends the hip joint and the long head I'm talking. and that's a hamstring. And rectus femoris is crossing the thighs. It's a muscle in front of thigh, so it is actually a flexor of the hip joint and extensor of the knee joint, right? So sartorius is actually flexor of both. It flexes both hip and the knee joint. Remember sartorius when you plan to sit down on the floor to eat maybe. So that is how, like, when you flex your hip and flex your knee. So, and that's why remember it's sartorius also called a tailor sit muscle. Okay, tailor sit muscle. And sartorius is also called, anybody? Any guesses? It is also called a honeymoon muscle. Honeymoon muscle. Okay. Then the next question here is, following are the contents of inguinal canal in male except. Now I'll have to be fast because if it goes long, it will not be uploaded. Long lectures are could not be easily uploaded. So I'll be fast now. The following are the contents of inguinal canal in male except ilioinguinal nerve, spermatic spermatic cord, artery to vas deferens, iliohypogastric nerve. The answer here will be iliohypogastric nerve. So remember that iliohypogastric nerve is not a content of inguinal canal. It stays out of the inguinal canal and it innervates. What segment? What does it innervates? Remember, it innervates the skin overlying the inguinal ligament. That's the inguinum. Okay, iliohypogastric nerve is not a content of inguinal canal in males, neither in females. Next question is question number 14. Conjoined tendon is formed by all except. The question is conjoined tendon is formed by external oblique plus internal oblique, external oblique plus transversus abdominis, internal oblique but transversus abdominis, internal oblique alone. So remember the fibers of the answer here is that the internal oblique but transversus abdominis muscle together, the fibers descend down, arch over this, forming the roof of the medial portion of the inguinal canal, and then they attach to this pubic crest. And so that is how, like, it is, that forms the conjoined tendon. It is like a support. It's like, it's supported rather, gives strength to this opening or the weakness of the superficial inguinal ring. So that's the conjoined tendon formed by internal oblique and transversus abdominis. The next question is, commonest point of appendix is, I believe I have taught this in detail in some other question, like I found thing from Ruhelkhand University or from Uttarakhand University or from Rajasthan University. I've also solved so many question papers. You go and find them. It has been solved in detail, expressed in details. Now, the commonest position of the appendix, of course, is retrocecal. They have given options as subcecal, pelvic, and uh, perileal. So pre-ileal, that is a wrong spelling here. So it is actually pre or post-ileal. So the commonest point of appendix, of course, is retrocecal, which is very common. The most common position is this, about I think 60% population, and then the next common position is like this. Remember somewhat, I'm not exactly very sure, rough an idea. So that's, I think I should not write it. It's the most common position is this. This is the most common position is retrocecal, or it might also be written as retrocolic. Okay, so retrocolic and retrocecal, don't confuse, they are the same, refers to the same position, and it is also mentioned as 12 o'clock position. Then the next is pelvic. Pelvic is next common. Next common position, if they ask, is pelvic, and pelvic is around 4 degrees. 4 o'clock. Sorry, 4 o'clock position. Okay. Question number 16 is nerve piercing and lying on psoas major is. This is a good question. The options is ilioinguinal nerve, iliohypogastric nerve, femoral nerve, genitofemoral nerve. You can add few more options here. That is little cutaneous nerve, thigh, obturator nerve, and all. So this you can remember like this is the spine, right? This is the spine, and let's say this is the sacropromontory. You have the iliac crest, and this let's say is the 12th nerve, right? So and you know psoas major, psoas major is actually like this, not very symmetrical in drawing, but psoas major actually descends down. It actually arises from these transverse processes of the lumbar vertebrae, and it descends down here into the greater pelvis. And when it reaches here, it merges with this muscle of the greater pelvis, and that is called iliacus. Together, both the muscles descend down to attach with the lesser tubercle of the femur, trochanter of the femur, and these two muscles are powerful flexors of the thigh. There is another muscle here uh, laterally, and this muscle is quadratus lumborum. Anyway, so basically we have to focus here upon this muscle, that is psoas major. Psoas major is this muscle, right? And this lumbar plexus arising from these L1, L2, L3, L4, right? And they were now forming. So, between this, this is how the nerves emerge on. One and two nerves, remember, it's here the kidney also is residing over to this, resting over to this. So, L1, these two nerves, all both of them are arising from L1 segments, and this is iliohypogastric nerve. This is also from L1 segment. Then ilioinguinal nerve. This also is from L1 segment. And down below, it will be this nerve, which will not be in relation to the kidney. However, behind this nerve is the posterior cutaneous nerve of thigh, right? This is L2, L3, dorsal division. And then you have is another big nerve, and this nerve actually descends down again between iliacus and psoas major and will reach into the thigh, and this is femoral nerve. This is femoral nerve. Okay. L2, L3, L4 dorsal division. Then obturator nerve emerges from here below to the medial nerve psoas major and descends right into the pelvis. Like this is again obturator nerve, and it arises from the ventral segment L2, L3, L4, right? L2, 3, 2, 3, and 4 ventral divisions. L2, 3, and 4 ventral divisions. This femoral nerve is L2, 3, and 4 dorsal division. Now the question is, which nerve is piercing and descending downwards towards major? So this muscle, remember, it is piercing. It is piercing. So I'm drawing it like this. So it piercing, and then it descends down onto the substance of psoas major, right? And this muscle is this nerve is, it is piercing and descending onto the psoas major. This nerve is, by till now you must have guessed it. The remaining option is yes. So this is genitofemoral nerve, right? L1, L2 ventral division. I taught you this in the scrotal or cremastic reflex before. I don't know, some question before. So this is genitofemoral nerve. Answer here is genitofemoral nerve, piercing and lying on psoas major. Okay. Question number 17 is, following are the boundaries of epiploic foramen except free edge of lesser omentum, quadrate lobe of the liver, first part of the duodenum, inferior vena cava. So for this, remember what I'm drawing is just in short to make you remember that let's consider that this is foramen epiploicum, or like Winslow, foramen of Winslow. This opening actually communicates the lesser sac behind the stomach, behind the lesser omentum, behind the caudate lobe of the liver. It's like behind. Now the bigger vast cavity is the greater sac. So there's a communication here at the lower free edge of this lesser omentum, or below to this just behind to this porta hepatis. So to make you remember, then just remember the names because of less of space and less of time. So I'm just writing here is anterior relations. Anterior relations is this. Here I'll be writing is the posterior relations, and here I'll be writing is the superior relations. Okay, and here I'll be writing the inferior. Actually, inferior is not the correct word. It should be antero-inferior. The better word is antero-inferior. Now, just remember superior relation if they ask. What lies superiorly and what lies posterior, anteriorly, and antero-inferior relations. Superiorly, it will be, remember, it is the caudate lobe of liver. And anteriorly, it will be porta hepatis. So porta hepatis means hepatic. सबसे पहले what will be there? Anterior to posterior. Yes, so anterior will be the bile duct. So it will be bile duct. Then hepatic artery. DAV is the formula, remember. And then you have portal vein. These all will be in anterior relation to this foramen epiploicum. Antero-inferior will be the first part of the duodenum. It will be the first part of duodenum, which will be antero-inferior related to foramen of epiploicum. Posterior relations, remember, IVC is one. Inferior vena cava will be posterior related. Then will be the suprarenal gland, right? So right suprarenal gland will be in posterior relation, and T12 vertebral level. So it's the T12 vertebrae that also lies behind to this foramen epiploicum. So this what I have drawn is foramen epiploicum, or foramen of Winslow. Those are the relations, remember this. Now the next question is left testicular vein drains into. So for that, remember this is inferior vena cava, right? These are the renal vessels, right and left renal veins, right? And where is this happening? Any guesses? Vertebral level between L1 L2. These are the two right and left renal veins. So, and you have is T12 to L3, that is the extent of the kidneys, right? And this kidney will be a little higher above T12 to L3. Now about the drainage. So, the gonadal veins here, that left testicular vein they have asked. So, left testicular vein actually drains into this left renal vein. This is left testicular vein, and this is IVC. This is right renal vein. Now about the right testicular vein. So right testicular vein will drain directly into the inferior vena cava. ठीक? Okay. Then another thing that drains into this left testicular vein is left suprarenal vein. Left suprarenal vein also drains directly into this left renal vein. However, the right suprarenal vein drains into this IVC directly. So these are the tributaries of left renal vein. Left testicular vein drains into, question is this. Choices is inferior vena cava, left renal vein, left intercostal, left internal iliac vein, left common iliac vein. Answer I have already told you is left renal vein. Question number 19. All are the contents of superficial perineal pouch except bulbourethral gland, superficial transverse perineum, dorsal nerve of penis, dorsal artery of penis. So it is an easy question. Remember that the bulbourethral glands are content of deep perineal pouch. Okay, rest of them here they are all the contents of superficial perineal pouch. And lastly, this question number 20 is, following are the tributaries of portal vein except right gastric vein, left gastric vein, splenic vein, inferior phrenic vein. So just a fast revision before I end up about this portal vein. This portal vein is being formed by superior mesenteric vein, splenic vein, right? All this is happening behind the neck of pancreas, remember, and there is this formation of portal vein. Okay, so this is portal vein. So remember that this is splenic vein, this is splenic vein, this is superior mesenteric vein, right? And inferior mesenteric vein, if they ask, like inferior mesenteric vein actually drains into, this is inferior mesenteric vein that drains into splenic vein. Now what is formed here is this thing called the portal vein. This is the portal vein. Now the tributaries, like what contributes, one is splenic vein, then you have superior mesenteric vein. What else contribute to the formation is like the tributaries. So one another is contribution by this, and this is from the duodenal portion, and that is called the superior pancreatico-duodenal vein. This is superior pancreatico-duodenal vein that drains into the portal vein. These are the direct tributaries, right? And along the stomach, remember, along this the left gastric vein and the right gastric vein, same as the course of arteries will be the vein course of this. Prepyloric vein is also like draining here from the pyloric region. And remember that this left gastric artery was also giving branches to the esophagus. Similarly, branches from esophagus also is being drained. The branches from esophagus was being through the left gastric vein that is being drained into the portal vein. Now before entering, it divides, like all these were actually contributing, means they were tributaries of the portal vein. Now if they ask what are the branches, this is a vein which has branches. So these are the branches. I'm using red here. This is the right portal vein and this is the left portal vein. So right portal vein also received now another tributary, and that is going like this. So this is receiving a vein that is called
cystic vein. Cystic vein also drains into the right, before this right portal vein enters into the right lobe of the liver, it receives a tributary from the cystic vein. Then about this left portal vein, remember before entering into the left lobe of the liver, it also gives branches to the, these are the branches. I've drawn it in arrow to the quadrate, hold on, this is caudate which is above. So this is caudate lobe of the liver, and for quadrate lobe of the liver, this is giving branches, and then it enters into the left lobe of the liver, left lobe. And remember the developmental thing, if they ask, like the remnants of this, umbilical veins, para-umbilical vein. So para-umbilical veins, which are actually remnant here, which are in the fetal life, they were running along the ligamentum teres. So so para-umbilical veins, these are para-umbilical veins. They also drain into the left hepatic portal vein, left branch of portal vein. And of course there will be communication of ductus venosus also. This is ductus venosus, that in an embryonic fetal life, there's ductus venosus which also drains into this left portal vein. But in adults, actually it's a remnant of this ligamentum venosum in adults. So these are all tributaries. Branches of portal vein, if they ask, like it's a vein. Normally veins do not have branches, they all have tributaries. So it's a vein which is having branches. So the branches of portal vein are like, to the lobes. One branch goes to the to the left lobe of the liver. This branch goes to the right lobe of the liver. So you have the branches reaching to the quadrate lobe, to the caudate lobe, to the left lobe, and to the right lobe of the liver. The rest, all of the veins you are seeing, they are tributaries of the portal vein. So I think this is done. And then it's a subjective portion, so it's done. Okay,